Hello, my name is Kiana Tolwe. I'm studying human biological sciences at the University of Montana, and today I will be discussing a case study regarding patient Mrs. W.T. First, we will begin by discussing the patient's history and her clinical workup at the time of her visit. Mrs. W.T. is a 74-year-old white female who is visiting for a routine checkup. At the time of her visit, she complains of mild back pain and is concerned she may have a UTI. During her exam, it will also become clear that she is hypertensive. Regarding patient history, it's important to note that Mrs. WT had a history of coronary artery disease, or CAD, and underwent bypass surgery in 2007 to repair a AAA, or abdominal aortic aneurysm. As for familial history, Mrs. WT's mother died of renal cell carcinoma and had a history of hypertension, ADPKD, or autosomal dominant polycystic kidney disease, and adult onset diabetes mellitus. Her father had a history of hypertension and died of a AAA. Mrs. WT's siblings have all been previously diagnosed with hypertension, CAD, and ADPKD. She also had a deceased brother that had a history of hypertension, hyperlipidemia, and a AAA as well. At the time of her visit, Mrs. WT states that she has been and currently feels stable, but would like to report her back pain and potential UTI. She has a normal temperature of 97.3 degrees and a blood pressure of 148 over 88. Considering a normal blood pressure is typically 120 or less systolic and 80 or less diastolic, Mrs. WT's blood pressure of 148 over 88 is concerning as it may be classified as stage 2 hypertensive. In regard to her laboratory workup, a urinalysis is conducted and comes back relatively normal. She has a urine pH of 5.5, which is within the normal range of 5 to 7, and has a normal specific gravity of 1.025, which is in the typical range of 1.001 to 1.035. With the exclusion of nitrates, Mrs. WT tests negative for a number of substances that would typically be considered abnormal constituents within the urine. These are things such as protein, glucose, white blood cells, ketones, urobilinogen, bilirubin, and blood, all of which Mrs. WT tests negative for. However, Mrs. WT does test positive for nitrates, which is often an indication of UTI or urinary tract infection, and it does confirm her original complaint. The normal urinalysis is positive and provides good evidence that her kidneys are functioning properly. Finally, it is important to note that a renal ultrasound shows multiple small cysts as well as bilateral enlargement of both of her kidneys. In order to diagnose Mrs. WT, it's important to consider her own and her familial medical history, her current complaints, as well as her physical and laboratory workup. The following information will detail 3 potential diagnoses based on Mrs. WT's presentation. First, ARPKD, or autosomal recessive polycystic kidney disease, is a hepatorenal fibrocystic disorder that results in enlarged kidneys, often due to bilateral kidney cysts and progressive loss of renal function. Additional symptoms often include things such as hypertension, portal hypertension or PH due to hepatic cysts, and congenital hepatic fibrosis or CHF due to ductal plate malformations of the portobiliary system. The most common site of abnormal cyst formation often occurs in the kidneys and the liver. Onset and subsequent diagnosis of this disease are often early, typically during gestation or shortly after birth, and mutation to the PKHD1 gene is the causative agent of ARPKD. Next, ADPKD, or autosomal dominant polycystic kidney disease, is an inherited genetic disorder that is commonly characterized by the formation of progressively enlarged fluid filled cysts within the kidneys. Common symptoms and comorbidities often include hypertension, back and side pain, kidney stones, UTI or kidney infection, as well as bilateral kidney cysts and enlarged kidneys. In contrast to ARPKD, typical onset and diagnosis of ADPKD is typically later in life, during the third, fourth, or fifth decade. The most common site of abnormal cyst formation of this disease is often in the kidneys, liver, and pancreas, and the causative gene of ADPKD is PKD1 or PKD2. Finally, TSC stands for tuberous sclerosis complex and is often referred to as TSC. TSC is an autosomal recessive mutation of the gene or genes TSC1 or TSC2, which encode for the proteins hamartin and tuberin, respectively. TSC1 and 2 are both tumor suppressor complexes that force G1 cell cycle arrest and often results in apoptosis. This abnormal expression of these proteins results in benign tumor growth in numerous organ systems, including things like the brain, kidneys, heart, lungs, eyes, and skin. Although the tumor growth may occur in a wide range of organ systems, renal disruptions are the second most common manifestation of TSC, and these renal disruptions often result in angiomyolymphoma formation, or AMLs, which form within the kidneys and destroy renal parenchyma, causing irreversible kidney damage. And unlike ARPKD and ADPKD, TSC occurs in both children and adults. When evaluating a patient, it is important to carefully compare and contrast each differential diagnosis with the patient presentation. Mrs. WT presents with a UTI, which is consistent with ADPKD, back pain, which is consistent with ADPKD as well, hypertension and enlarged kidneys, which is consistent with both ARPKD and ADPKD, and cystic formation of the kidneys, which is mostly consistent with all three diagnoses. However, it'll be important to distinguish what type of growth or formation is present. Her current lack of diagnosis is inconsistent with ARPKD because it's typically diagnosed early in life and she has yet to get a diagnosis. At this time, she exhibits no extrarenal growth, which provides no conclusive evidence. And she has not had any genetic testing, which would provide conclusive indication of the causative gene and the autosomal nature of her disease. Mrs. WT's final diagnosis is ADPKD because she does not exhibit tumor growth, but rather cystic growth, and her neuro and psychiatric evaluations are normal. TSC can be ruled out. And although it's not always true of ARPKD, Mrs. WT's lack of early diagnosis, as well as her lack of hepatic cysts and CHF, which are typically comorbid, allow us to rule out ARPKD. Next, her familial history of ADPKD as well as AAA may be used as supportive evidence to rule in ADPKD because abdominal aortic aneurysms, AAA, are often comorbid with ADPKD, and because it's an autosomal dominant disease, this indicates that Mrs. WT would have had a high probability of developing the disease based on her mother having had it as well. As mentioned previously, genetic testing is available to confirm the mutated gene causing the disease, which would also confirm the diagnosis. However, this type of genetic testing is often pretty costly and not necessary if the patient doesn't require it or desire it. Next, it's important to consider treatment following diagnosis of new disease. There are two treatment options that are available to those with ADPKD. The first is symptom management. This type of treatment, specific to Mrs. WT, would involve the use of medication to treat her hypertension. At this time, the most detrimental symptom of ADPKD that Mrs. WT exhibits is hypertension, which can cause strain on blood vessels within the kidneys that could result in irreversible kidney damage. It's important to minimize damage of the kidney blood vessels because damaged vessels become less effective in filtering blood, which can result in high levels of blood toxins that may eventually require dialysis. The second treatment option involves the drug tolvaptan. In 2018, the FDA approved tolvaptan as the first drug treatment to slow kidney function decline in those at risk of rapidly progressing ADPKD. While this treatment option has shown good results since it entered the market, Mrs. WT does not officially qualify for the treatment. Qualifying for this treatment necessitates the confirmation of a rapidly progressing disease, which requires both a Mayo classification of 1C, 1D, or 1E, as well as the patient's healthcare provider considering the patient's age, TKV or total kidney volume, and eGFR or estimated glomerular filtration rate. Although Mrs. WT has renal cysts and has since been diagnosed with typical ADPKD, her TKV and eGFR have not been tested, meaning she can't be considered. And regardless, when considering her urinalysis, the relatively normal results provide little indication of kidney damage at this time, indicating that Mrs. WT's disease is not rapidly progressing. She also doesn't fall into the age range that is shown on the chart that specifies the qualifying ages, which are between 18 and 55. Because she does not qualify for the second treatment option of tolvaptan, it's recommended that Mrs. WT's hypertension be treated. To do so, she's prescribed 5 milligrams of Norvsac or amlodipine mesylate, which is a calcium channel blocker, and it's to be taken once per day. Calcium channel blockers are useful in treating hypertension because they lower blood pressure by preventing calcium from entering the blood cells of the heart and arteries. Cardiac muscle contraction is initiated due to the entry of calcium ions into the sarcoplasm. So as a result, when calcium channels are blocked, blood vessels are forced to relax and open, resulting in less forceful contraction and overall lower blood pressure. Symptom management is a standard means of care to treat ADPKD and should do little to change her quality of life, considering calcium channel blockers have mild potential side effects. These are things such as constipation, dizziness, heart palpitations, and fatigue, and all of these can be treated with additional medication or reevaluation if necessary. Overall, Mrs. WT has good short-term prognosis with little immediate risk considering she's stable and shows little indication of kidney damage at the time of her visit. It will be important to monitor Mrs. WT's relative kidney function as well as ensure she understands her long-term prognosis. There's no true cure for ADPKD, and progressive loss of kidney function is one of the most serious complications of the disease. Therefore, regardless of treatment regimen, it is likely that Mrs. WT's disease and loss of kidney function will continue to progress. In summary, Mrs. WT is a 74-year-old woman that visits for a routine checkup and complains of back pain and potential UTI. Her normal laboratory workup indicates little to no kidney damage, but renal imaging in combination with familial history supports the diagnosis of ADPKD. Mrs. WT is prescribed 5 milligrams of Norvsac to be taken once per day to treat her current hypertension with the purpose of avoiding kidney damage. Her overall prognosis is good, however, there is no true cure for ADPKD, and it is therefore important that she continues routine visits to monitor the progression of her disease. Here are the reference materials that were used to compose the information within this case study.